everyone, and welcome to today's webinar, Supporting Infant Sleep, a Suite of Tools for Public Health Nurses. My name is Andrea Bodkin. I'm a Senior Program Specialist at Public Health Ontario, and I am happy to co-moderate today's webinar. I'm coming to you today from the PHO office on Treaty Lands and Territory of the Mississaugas of the Credit First Nation, Treaty 13. These are lands associated with the Toronto Purchase of 1805, and today these lands are called the cities of Etobicoke, Toronto, North York, and Vaughan. These have been the historical and ancestral lands of many First Nations for thousands of years. People who lived, hunted, traded, traveled, learned, and prospered on this land. These First Nations included the Haudenosaunee, the Huron-Wendat, and most recently the Mississaugas of the Credit. I'm grateful to have the opportunity to live, learn, laugh, and work on these lands. I'm happy to introduce my co-moderator for today's session, Sonia Strom. Sonia is the program manager for the Public Health Nursing Practice Research and Education Program, PHN Prep, at McMaster University School of Nursing. She supports project management, research, and knowledge translation, collaborating with public health nurses and managers in Ontario's Healthy Babies, Healthy Children and Nurse Family Partnership programs. Sonia, thank you for being here, and I'll hand the mic over to you.
Thank you, Andrea, for the warm welcome, and thanks to your amazing team at Public Health Ontario. I'm thrilled to be here today, co-moderating with you and representing the work of the PHN Prep team in supporting public health nurses, supervisors, managers, and home visiting staff in their work with families. And it's now my pleasure to introduce the speakers for today's presentation, Anya Cahill, Ricky Goba, and Nicole Strangway. Anya Cahill is the nursing practice lead for Ontario's Parent-Child Relationship Program. She supports NCAST PCI scale instructors across 29 public health units and collaborates with PHN Prep, Ontario's Ministry of Children, Community and Social Services, and the Barnard Center at the University of Washington. Ricky Goba earned her nursing degree from Brock University and is set to complete her Master of Public Health and Nursing at Lakehead University in April of 2025. With 12 years of experience as a public health nurse at Niagara Region Public Health, she has focused on high-risk home visiting in the Family and Community Health Division. She now leads the Nurse Family Partnership Program, supporting first-time parents under 25 years old. Nicole Strangway has been with Lambton Public Health's Healthy Babies, Healthy Children program for 11 years, supporting rural families as a prenatal educator and postpartum support co-facilitator. She has also been an NCAST PCI instructor for 3 years. So these 3 individuals have been part of a working group, and they're here today to share about their work. I'm really excited for all of you to hear, and I'm going to pass it over right now to Anya.
Thank you, Sonia, for these kind introductions. Ricky, Nicole, and myself are very excited to be here today to introduce this suite of tools and resources for public health nurses regarding healthy infant sleep. This presentation and all of the materials that we will be introducing today were developed by the PHN Prep Sleep Activity Working Group. These materials are available for download on the PHN Prep Virtual Community of Practice. This webinar is being recorded and will be shared on the virtual community of practice. So topics today will include the history and background of the Sleep Activity Working Group and their development of the suite of tools. We will review the suite of sleep resources, which include professional resources for home visiting staff, client-facing resources that are intended to be provided to clients as needed, and the Sleep, Feed, and Play Tracker, an optional tool that we hope you will find is an integral component of assessing sleep health and routines with families. Today's resources are available already for download from the PHN Prep Virtual Community of Practice in English, and French language client-facing resources will be available at the end of March. At the conclusion of the presentation, there will be an opportunity for questions from the viewers. So our hope is that by the end of this session, participants will have an enhanced knowledge of normal sleep expectations or know where you can access credible information to describe these. We're hoping you'll become more aware of professional resources to guide client assessment, intervention, and evaluation regarding perceived sleep concerns. And finally, feel empowered to implement the sleep, feed, and play tracker into your practice whenever applicable. So first, why infant sleep? Infant sleep training was identified as an area in need of professional development support and priority for HBHC public health nurses by PHN Prep through engagement activities with health unit management in 2022, culminating in the report, Healthy Babies, Healthy Children, Program Practices, Processes, and Policies, Reflections from Ontario's Health Units, published in May of 2023. Simultaneously, the Ontario NCAST PCI instructors were raising questions about the potential suitability of the PCRP Sleep Activity Program for use in Ontario's home visiting programs as a foundational tool. As a result, the PHN Prep Sleep Activity Working Group was struck to source evidence-based information to support Ontario public health nurses working in the Healthy Babies, Healthy Children program, to support caregivers in developing healthy sleep practices for the family, including realistic development-related expectations of sleep and activity cycles, and the development of effective and supportive daily routines. The scope of the working group included an understanding that materials created or supported by this working group would need to be BFI compliant and not contradict Health Canada or the Public Health Agency of Canada's safe sleep recommendations. However, materials sourced or developed by this working group would not directly address bed sharing or swaddling or safe sleep, injury prevention, or risk reduction related to infant sleeping arrangements or environments. These areas of sleep are well researched, and numerous existing safe sleep supports are accessible to Ontario's home visiting PHNs. To support these outcomes, the Sleep Activity Working Group is co-chaired by PHN Prep Program Manager Sonia Strom and myself. And it consists of NCAST PCI instructors representing all 7 public health regions in Ontario. The group includes intentional diversity between rural, suburban, and urban populations, as well as diversity of additional features, such as the inclusion of health unit representation that are baby-friendly designated or have Indigenous communities within their geographical boundaries, or offer the nurse-family partnership in addition to Healthy Babies, Healthy Children, or have blended and non-blended home visiting structures, or represent the spectrum of use of existing sleep resources, or perhaps have developed their own internal sleep resources. And just to note, all NCAST PCI instructors are educated in the parent-child relationship program's sleep activity program materials, including use of the beginning rhythm manual and sleep activity record as part of their instruction to become an instructor. And finally, Ricky Goba and Debbie Hunter joined the working group as content experts in 2024. So the goal of the working group was to support the development of home visiting nursing knowledge and messaging regarding healthy infant sleep. The group formed in the summer of 2023 and has met at least monthly since that September. The initial focus was on a review of existing resources and materials that support healthy infant sleep. The group coordinated the February 2024 PHN Prep webinar, Promoting and Supporting Sleep Health in Families of Infants by Dr. Elizabeth Keys, and facilitated the publishing of the PHN Prep professional resource, Promoting and Supporting Sleep Health in Families of Infants, in October 2024. While simultaneously working through and reviewing existing materials that support healthy sleep. In January 2024, locally developed sleep resources from Niagara Region Public Health were selected to be adapted by the Sleep Activity Working Group. And now to share additional information about Niagara Region's sleep health journey is Ricky.
Thanks so much, Anya. So I want to take us back to 2015. So that's 10 years ago, if you can believe it. In Niagara Region, we have a telephone line that parents and caregivers can call into and ask questions. That line at the time was referred to as our parent talk line. So on our parent talk line, through a data analysis, we noticed that parents of infants 0 to 12 months of age We're calling in asking for more than just information on safe sleep. As Anya mentioned previously, there's lots of information and resources on safe sleep, but parents were really looking for how to manage the sleep concerns that they were experiencing with their babies at the time. We then decided to do an environmental scan and a literature review to look more into this topic, to see how we can help the residents of Niagara Region who are parenting and struggling with infant sleep. An environmental scan was completed with our community partners, our family health staff, and childcare centers that were responsible for infants across Niagara Region. We sent out a survey and asked them to identify some of the most frequent questions or concerns that parents had, as well as some of the gaps in resources that they were seeing. Our environmental scan showed some of the most frequently asked questions to be the following 9 points up on your screen. The first being infants not sleeping for long periods of time, not sleeping through the night. When will that happen for us? Lots of questions about co-sleeping, prevention of sudden infant death syndrome or SIDS, concerns about the head shape of their baby because they were sleeping on their backs now, questions about sleep patterns, like their baby is up very early or falls asleep very late, mixing up their days and nights, how to get baby on a schedule and get a routine in place. Also, how to keep up with that changing schedule or changing sleep patterns as the baby grows. They were also asking why babies sleep when they're in their stroller or out and about, but not necessarily at home in their crib where they need them to sleep. Also, they were questioning why baby wakes up and needs a soother or a bottle in order to transition back to sleep. So based on this environmental scan and these specific questions that we saw come through, we reached out to Dr. Wendy Hall, who is at the University of British Columbia, and she spends lots of her time researching and studying infant sleep and its impacts on parenting. She agreed to work with us on creating a program to support Niagara's parents around this infant sleep topic. She conducted a literature review, and the literature supported a need for parental guidance around infant sleep concerns. Parental adjustments to infant sleep patterns and behaviors was identified in the literature as affecting things such as parental behavior, maternal health, maternal sleep, postpartum mood disorders, and marital satisfaction. As a result, we were able to compile all this literature, address some of the topics, and create the workshop that we referred to lovingly as Key to Get Some Z's, 0 to 12 months. We rolled out this workshop in person in a variety of different community partner settings across Niagara. So fast forward just a little while further to 2016. While the workshop was well attended and parents were giving good feedback about the information, an evaluation of the workshop was conducted, and we heard from parents that they were reporting they liked the information and the support received in the workshop from other parents, but at times they found it was too much. It was overwhelming. There was way too much information being shared from 0 to 12 months. They really wanted a more individualized support for their sleep concerns. We also saw that there was a gap in perceived knowledge from staff who were a part of focus groups, sharing that they wanted more training. They had increased training needs in this topic. Dr. Wendy Hall agreed to apply for a grant to support this training of PHNs and increase our practitioner knowledge about delivering infant sleep programs in the Niagara region. Dr. Hall was then able to update the literature review with current research around behavioral sleep interventions for babies 6 months and older. This review showed a few highlights. One of them being that sleep problems in infancy can continue into childhood, and sleep deprivation can lead to health and behavioral problems in children. Behavioral interventions improved infant sleep overall, and that maternal depression and anxiety, as well as stress, were decreased with these interventions. The use of controlled comforting is one example of an behavioral intervention and is used with to help with infants older than 6 months of age and help them learn how to self-soothe and self-settle with minimal parental interference. That's the key with this. It is one of the most recommended behavioral strategies for sleep problems in babies older than 6 months, and evidence does not indicate that it leads to later emotional or behavioral problems in children, which is often the concern that comes up when we introduce some behavioral interventions. Literature supports that parents do better with support when implementing these interventions, though. A study that was conducted shows that when parents try to use the strategy on their own, like controlled comforting, success rates tend to be lower, and therefore the parents benefit from having structured instruction and support. The more support they have, the lower the stress for both the parent and the infant that is going through this transition. One thing that the studies had in common was that it was beneficial to have one-on-one consultation in order to individualize a plan that is right for the family. We really want to look at the family's unique needs, and they're different across the span. It's also consistent with what parents reported on our workshop evaluation. As a result, there was a rationale for program change. This is what would provide a broader scope of information to parents in regards to their infant sleep. We wanted to reach parents at an earlier stage in their baby's development to increase the likelihood of parents having realistic expectations of infant sleep. We want to make sure that based on age and stage and development, as well as their family needs, their expectations were set at a place that was attainable and realistic for that child. We created a work plan, which included a communication plan and campaign to reach the population of parents, promoting key messages and tips for parents with babies 0 to 12 months of age. We really wanted to normalize infant sleep behaviors and expectations. We want to make sure that we had realistic expectations for babies through our sleep messaging that we could share with parents. Additionally, we wanted to provide resources and information on how to access programming or support for parents in the Niagara region. We created tip sheets that were categorized, developmentally. So we addressed newborn to 3 months, 3 months to 6 months, and 6 months to 12 months, because they have different needs at different times. As a result of this grant and the literature review that was done, we wanted to update our workshop so that it was more focused on 6 to 12 months when we are providing behavioral interventions. This included physiology of sleep, ways to promote attachment, nap time and bedtime routines, safe sleep, tips and strategies to promote sleep, and overcome sleep problems. We really were intending to create client-centered sleep plans during that workshop time and receive one-to-one follow-up telephone calls with each client. We were able to publish a paper with Dr. Wendy Hall and a number of nurses from Niagara Region Public Health that have done such great work, entitled Dissemination of Evidence-Based Interventions for Pediatric Sleep Disorders, the Niagara Project, Process and Outcomes. You can find this online. And we were also benefited with the opportunity to hold a CME event hosted for physicians entitled Attending to Pediatric Sleep, Pathophysiological and Behavioral Sleep Problems, in which it was presented by Dr. Shelley Weiss, a pediatric neurosurgeon from the Hospital for Sick Children in Toronto, as well as our own Dr. Wendy Hall from University of British Columbia, who did so much great work with us in the Niagara region. Fast forward a little bit here, going to 2020, we had received a grant for a Train the Trainer so that we could go into childcare centers and train the ECEs in having sleep-focused conversations with parents in real time at drop-off or pickup, when maybe they would have the opportunity to have some consistent touch bases with these parents about these topics. Unfortunately, this did not happen due to COVID. As we all know, in 2020, things were shutting down. Daycare providers were not as easily accessible. Many of our public health resources were redirected to support the pandemic efforts. And then we saw an increased shortage of daycare staff and ECEs in the community. Unfortunately, we weren't able to follow through on this grant. We really wanted to revisit the workshops after we were able to get more of our public health staff back into our programming and family health. We created virtual infant sleep groups. They were not always well attended, unfortunately. We also attempted to create an increased engagement with our community partners and offer Train the Trainer to places like Early-Ons or local centers where families would naturally be. Unfortunately, resources were limited and it was not a success. We then decided to create a working group to identify how to adapt our current curriculum from the workshop and supports in order to implement them across family health in one-to-one interactions through Niagara Parents, our telephone line that's now adapted from the original Parent Talk line, as well as our home visiting teams. Within the working group, we included health promoters, Healthy Babies, Healthy Children, PHNs, nurse-family partnership PHNs, family home visitors, as well as reproductive and child health PHNs. So our whole team was on this working group, identifying ways that we can utilize this information and support parents in real time. The group created a training program for staff, including videos as well as in-person training sessions, with the focus of utilizing and creating individualized family sleep plans that focused on the unique needs of each client and could be applied in any client care setting.
Thank you so much, Ricky. And I think you've painted a really great picture for everyone viewing today on just why the Sleep Activity Working Group made the selection and the decision to go with the Niagara locally developed resources. So once that decision was made in January of 2024, the HBHC program managers and supervisors were surveyed to comment on the suitability and acceptability of these resources for use within their own agency. This information, oodles of feedback, was collected, and it was critical in the development of the resources that will be shared today. A report outlining the selection process and recommendations for moving forward was submitted by the working group to the Program and Service System Effectiveness Unit of the Ontario Ministry of Children, Community and Social Services, titled The Assessment of Sleep Resources, Recommendations for Healthy Babies, Healthy Children, in March of 2024. Funding was provided for the continuation of the PHN Prep Sleep Activity Working Group to support completion of the working group goals. Over the past year, the PHN Prep Sleep Activity Working Group has been reviewing, evaluating, and updating the Niagara Region sleep resources for suitability and acceptability for use in all of the home visiting programs across Ontario. We followed the PHN Prep Practice-Informed Guidance Framework and had the materials reviewed by experts, including Dr. Wendy Hall, and were heavily influenced by the work of Dr. Elizabeth Keys. Today, we are excited to launch this suite of sleep tools and resources for Ontario's home visiting public health nurses. And I'm excited to turn the presentation over to Nicole to begin sharing these resources.
Thank you, Anya. Good morning, everybody. So I'm going to start with the suite of sleep tools and resources. So the intention of the working group in creating this suite of tools and resources is to provide helpful ideas and approaches that can be made available to all parents based on their unique family needs and wants related to their infant sleep concerns. This is not an all or nothing approach, though. These tools are intended to help parents make informed decisions for themselves and their babies when it comes to infant sleep queries. All handouts available to download from the PHN Prep virtual community of practice in English presently, and client-facing resources will be added in French by the end of the month. These are optional resources to add to your home visiting materials. They can be customized with your health unit's branding, parenting support information, and so on. We will review each of the materials from the suite, beginning with the professional resources. So the professional resources were developed for use by nurses and follow the nursing process, or ADPI. So this includes 3 professional resources to support nurses in their understanding of healthy infant sleep, as well as the selection and implementation of interventions to support the development of healthy sleep patterns for the families that they work with. These resources are available in English only, and a list of resources have been published to accompany the resources. Okay, so understanding sleep health in families of infants is the first in the series of professional resources. All professional resources are identified as such in the top right-hand corner there. They are intended for staff and are not recommended to be provided to our clients. This resource explores information essential for home visiting staff to support families in making sleep-related decisions. The first page begins with a glossary of sleep terms which may be new to some nurses. So followed by a review of the domains of pediatric sleep health, as was introduced by Dr. Elizabeth Keys in the PHN Prep webinar on promoting and supporting sleep health in families of infants. The domains of pediatric sleep health are further explored with a detailed review of typical expectations and foundational knowledge. This information is intended to be used as a reference and resource for nurses as they interpret assessment findings with their clients related to their infant's sleep health. So as an example, sleep efficiency, which is one of the domains of pediatric sleep health, is defined within the glossary as the amount of sleep a person actually gets divided by the total amount of time a person is sleeping and trying to sleep. Within the domains of pediatric sleep health table, a nurse will find such information as typical expectations, including that sleep efficiency can be affected by sleep latency and nocturnal wakefulness, with age-related expectations identified. You will also see the foundational knowledge, including that it is normal to wake through the night, that sleep latency is influenced by sleep associations and the presence or absence of these conditions, and that babies learn to combine sleep cycles, consolidating sleep periods, and improve sleep efficiency over time. Okay, so then on the third page of this, factors that may influence sleep are introduced at the level of the infant, parent, family, and society. There's also a note there describing concerns that would prompt further assessment by a healthcare provider, such as if you have an infant snoring, breathing difficulties during sleep, feeding or waking concerns, and multiple regulatory concerns. And then each professional resource ends with links to resources, references, and citations as applicable. Okay, so with a baseline of infant sleep knowledge, nurses are encouraged to further assess the sleep health of the families they work with. This second professional resource, called Assessing Sleep Health in Families, provides key information and practical guidance for confirming a family's interest in discussing healthy sleep, also exploring factors that can interact with sleep for the family, including infant factors, parental factors, familial factors, and sociocultural factors, building on information obtained from that first professional resource that we just went over called Understanding Sleep Health Families and Infants. It is recommended that issues related to the mental health of caregivers and the parent-child relationship is assessed to implementing any sleep strategies. So this can be facilitated through use of things like the Edinburgh, NCAS feeding and teaching skills, the patient health questionnaire, so the PHQ-9, and then as per agency policies as well. Okay. So the second page provides numerous example questions that encourage that non-judgmental, culturally humble, client-focused assessment with the family and can be woven into conversation during home visits with the family. Okay, so assessing sleep health in families. So the Sleep Feed Play Tracker is a client-completed tool for documenting their infant's sleep, feeding, and playing routines. Is also introduced in this document as part of the assessment process. So using the family's recorded information from the Sleep Feed and Play Tracker, the nurse can assess the duration, the timing, the sleep latency and nocturnal wakefulness, alertness during waking hours, and nutrition. So let's take a look at the Sleep Feed and Play Tracker in more detail. So the Sleep Feed and Play Tracker was originally developed by Niagara Region Public Health and Emergency Services with the foundation in the work of nurse researcher Dr. Wendy Hall. This is a parent caregiver completed pencil and paper data collection tool that can be discussed with families as an option to gathering sleep health and other routine related information. This tool does not need to be completed with every family. Consider it an optional information collection tool that can be implemented with families who are interested and able to manage this type of tool. Information for the nurse about the sleep feed and play tracker can be found in the Assessing Sleep Health and Families Professional resource. So instructions for the client are provided on the reverse side of the form. The expectation is that the nurse would teach the client how to record the desired information on the form through the completion of a 24-hour recall. So you can leave the tracker with the client, who would then complete the tool for up to 5 consecutive days between visits, and then the nurse would collect the form, analyze the information, and discuss potential interventions at subsequent home visits. The nurse's use of the sleep feed and play tracker is support through 2 appendices. So we have Appendix A, which is nursing instructions for completing and evaluating the sleep feed and play tracker. It provides step-by-step instructions, including suggestions for engaging the client in completion, areas to calculate to support analysis and select interventions. And then we have Appendix B. So this worksheet for nursing evaluation of the sleep feed and play tracker data. So it includes data collection tables to guide the collection and analysis of data as per Appendix A. Together, these 2 support documents will allow the nurse to interpret information on the family's sleeping, feeding, and playing behaviors and relate that back to evidence-based norms to support the selection of interventions that then can be discussed with the client. Again, this sleep feed play tracker is optional data collection tool that may not be suitable for every family. Nurses should be encouraged to implement with families who have the capacity and supports to successfully use this tool. Families may also utilize other methods of data collection. Nurses can work with families to complete a sleep feed and play tracker using the data the client has collected from other sources, so like a notebook or an app. This tool will be available in French language by the end of March. As a suggestion to familiarize yourself with these tools and supports, so try tracking your own behaviors for a few days. Follow the instructions and use the worksheet to analyze your own routine data.
Thank you, Nicole. And I get the opportunity to share the third and final professional resource. And this one is called Interventions to Promote Sleep, Supporting Families and Their Management of Sleep Concerns. This resource outlines a stepped or sequenced process for providing support to families regarding their infant and family sleep health, following the assessment of their sleep behaviors or concerns. The idea to use this tiered approach when providing sleep information to support parents who have identified infant sleep challenges or concerns. Begin with exploring what is currently happening with the family and the baby, supporting a starting point where parents can discuss developmentally appropriate and supportive strategies, and in doing so in a gradual way that supports the family's unique goals, relationships, and infant development. So the 4 steps in this sequenced process include, first, providing anticipatory guidance. We want to share with all families what they can expect regarding age-appropriate sleep behaviors, the factors that can influence sleep, how sleep habits develop, and the importance of social supports. This information can even be shared prenatally. There are 2 client-facing resources that will be discussed shortly to support nurses in providing this anticipatory guidance. And these include a baby sleep guide for birth to 6 months and a baby sleep guide 6 to 12 months. The second step would be to build sleep promoting behaviors and routines. This is working with caregivers to develop consistent daily routines and other sleep promoting behaviors such as warm, responsive parent-child relationships, physical activity, and establishing comfortable and safe sleeping environments. The third step would be to build the plan with caregivers for their infant to learn new sustainable sleep associations if they're needed. And finally, is to consider specialized care or further assessment when that's warranted. The third page of this resource links tips, considerations, and interventions back to the pediatric sleep health domains that were introduced in the first professional resource, Understanding Sleep Health in Infants. So back to our example of efficiency in the sleep health domains. So efficiency, again, it was defined in Understanding Sleep Health as the amount of sleep a person actually gets divided by the total amount of time a person is sleeping or trying to sleep. This document outlines that a pattern of 3 or more wakings per night might be considered a problem by caregivers. A tangible intervention suggested is to support families in learning to differentiate their infants' cues during wakings, such as hunger cues versus sounds of active sleep. Further in the resource are evidence-based sleep interventions, including cue-based care, pre-sleep routines, and 2 behavior-based sleep strategies. Where possible, resources and interventions that are already being utilized in the HBHC program are included. So for example, specific reference to keys to infant caregiving booklets and pipe lessons have been identified. So for more on the behavior-based sleep strategies, I'll call on Ricky.
So I wanted to talk a little bit today about the behavioral interventions that were referred to previously. Often these can be seen as controversial, but we want to really enforce the fact that these interventions are for people who want them. We are not pushing any interventions on any particular family, as every family has unique needs and different challenges that they're facing. If a parent were interested in behavioral interventions, these are the most common type, and these are some that we've implemented into your resources. So on page 7, 4 behavioral-based sleep strategies are reviewed. These include things like bedtime fading for babies of any age, camping out and controlled comforting for babies over 6 months of age, and then the topic of crying it out, which is described, but just so you know, it's not recommended as a strategy at any age. A number of steps are identified to guide the nurse's practice prior to discussing camping out or controlled comforting as an intervention. So working with the family to develop age-appropriate daytime and pre-sleep routines is absolutely paramount. Supporting the family in identifying and responding to their infant's cues, as well as discussing other sleep-promoting behaviors, can also be done. We would additionally want to discuss things that Anya's just mentioned. So NCAST and PCI feeding scales are teaching skills to assess that parent-child relationship. And we want to offer mental health screening of the caregivers. Some of the interventions described will provide you with key things to talk with your families about related to these topics, like, is the baby well? Is the family in the right space and time with routines in order to be able to provide these interventions? And all of your resources will go through this. Thanks for letting me speak to that, Anya.
Thank you so much, Ricky. Let's see. The last piece of professional resources, just want to call attention to the end of interventions to promote sleep, where there is a sub box there of additional Canadian resources for staff. So feel free to reference these as you need to continue to build your sleep health information and capacity. And without further ado, we can move to the client-facing resources with Nicole.
So thank you, Anya. Okay, so on to the client-facing resources. So in addition to the sleep, feed, and play tracker that we have already reviewed today, there are 4 more client-facing resources that we can use. So they're each written in about a grade 4 literacy level and will be released in French as well. So these include 2 sleep guides for babies. So we have the birth to 6 months, and then we have the 6 months through the 12 months. And then we have 2 resources on sleep strategies, and they are called controlled comforting and camping out. So let's dive into these in a little more detail. Okay, so first, the baby sleep guides. So 2 guides have been developed to support the provision of anticipatory guidance related to healthy sleep and sleep expectations of infants. These resources can be used to support nursing knowledge, such as during program orientation, and are intended to also be shared with clients, optionally and when applicable. Materials developed that are appropriate to share with clients are identified by the name in the top right corner there. So baby sleep guides include the baby sleep guide from birth to 6 months of age, and then again from 6 to 12 months of age. So both of these resources outline age-appropriate information on sleep activity, cycles, and cues, plus tangible things that parents and caregivers can do to support the development of healthy sleep behaviors and pre-sleep routines with their infant. So Baby Sleep Guide, Birth to 6 Months, further breaks down the development of sleep patterns into the first 3 months and also from 4 to 6 months. And they offer tangible tips to promote sleep in this age group. So information for the caregiver on responding to baby's cues and also developing pre-sleep routines. And then it has a section as well about how to take care of themselves. So these are all reviewed in the sleep guidelines. Okay, and now I'm going to pass back to Anya.
Thanks, Nicole. So our last 2 client-facing resources describe the behavior-based strategies that could be implemented in addition to health teaching in the home with clients as applicable. So these include camping out, sleep strategies for babies over 6 months, and controlled comforting. Again, sleep strategies for babies over 6 months. So both of these behavior-based sleep strategy handouts review how a family would know that they are ready to try implementing a sleep strategies. So families would need to be able to answer yes to all of the following: that the caregiver and their parenting team have found that the sleep associations used by the baby to fall asleep are becoming a problem, that they are ready to use a sleep strategy to help their baby fall asleep on their own, and that they understand that a sleep strategy needs to be planned for and followed consistently by everyone who puts the baby to bed. The family and the team need to be feeling physically and emotionally well. In case of the baby needs to be at least 6 months old. They need to be meeting their healthcare providers' expectations of growth and development, and not consistently show signs of worry when apart from the caregiver. The baby also needs to be feeling well, including not teething. The family needs to confirm that they spend quality time together during the day and already have established pre-sleep routines, regular bedtimes, and are not experiencing any other changes or transitions. If families are interested in implementing behavior-based sleep strategies, but can't quite answer yes to all of these items, the nurse can go back to the Assessing Sleep Health and Interventions to Promote Sleep Health professional resources and work with the family to develop a plan of care that will support the family in meeting all of these criteria. Through the process of doing this, the family may find that developing these missing items will actually improve their baby's sleep enough such that implementing a behavior-based sleep strategy is no longer needed. Another thing to note on both of the behavior-based sleep strategy handouts is a review of the things to be considered. So these are key points that a family should be aware of prior to implementing behavior-based sleep strategies. They vary slightly between the 2 handouts, but in general, a family should be aware that sleep strategies are not instant fixes and they will take time to work. The caregiver should continue to respond to their baby during the day as they normally would. and not to begin a sleep strategy if the baby is sick, teething, or going through a big transition. Should the baby become sick, the sleep strategy should be paused. It's also important to note that sounds can be normal while the baby is learning to fall asleep on their own. The caregiver should be encouraged to use their support network, and so on. Each resource provides the family with step-by-step instructions on how to safely implement the sleep strategy. This information should be reviewed in detail by the nurse, and the handout can be left if it's needed to act as a reference or to share information with others who may be caring for the baby. So I've got clips here on the screen, one from Steps for Controlled Comforting, the other is Steps for Camping Out. And the nurse should carefully review and consider these steps in their preparation for a home visit that they might be sharing these strategies with a family. So feel really good about how to do these before implementing it as an idea with a family. And finally, it's important to know that all of the client-facing resources end with a need help box that redirects caregivers to their public health nurse or healthcare provider, as well as an area that can be customized with the local health unit's parenting or support information. You could put telephone lines in here, web pages, or information about the Healthy Babies, Healthy Children program. And there's also a scannable QR code available that would bring the client to a PDF list of all the references that underpin these resources. So here's an example of what a client or a caregiver or yourself as staff would see when they access the references QR code. There are 4 pages of references here in a PDF, and it can also be downloaded from the PHN Prep website. So as discussed in the beginning of our session today, this suite of tools and resources is not a one-size-fits-all program. These tools should be selected and adapted based on client need, capacity, and interest. In general, here is a suggested flow of the tools and resources, noting that not every step will apply to every family. So first, a nurse would provide anticipatory guidance and information about sleep and normalized expectations to all families, prenatally if possible, including an emphasis on cue-based care and the development of sustainable pre-sleep routines. To do this, you're welcome to share the age-appropriate baby sleep guide. As Nicole mentioned, there's one from birth to 6 months, which would be great to give to a prenatal client so they can learn and anticipate what's to come regarding sleep with their infant once they're born and come home. Or you can start with a later resource, 6 to 12 months, should you be bringing on a family with an older baby. So you can also confirm the caregiver's interest if additional sleep-related support is identified once they've received all of the anticipatory guidance and normal expectations. Should interest in additional sleep support be identified, we encourage you to assess caregiver mental health and the status of the parent-child relationship using our validated screening and assessment tools. While you're doing that, you'll also assess the family's sleep health needs using the open-ended questions and the sleep feed and play tracker if it's appropriate. Nurses will then use all of this assessment information to help the family with developing and implementing sleep-promoting behaviors and daily routines. Finally, when warranted, the nurse can support the family with implementing behavior-based sleep strategies or consider need for further assessment, such as for regulatory issues. This is a large suite of tools, 3 specific professional resources, 4 specific client-facing resources, and the sleep feed and play tracker, which is used by the client and supported by the nurse. There was 2 years worth of work from the sleep activity group that built upon 10 years of work from Niagara Region Public Health. So there's a lot of content here, and I would really encourage you to take your time and review each of the resources individually. Reflect on it, share it with your team, have discussions, and see how to implement these pieces into the work that you do with Ontario's families. To remind you, there are existing supports to even further underpin this sleep health information. So for example, Dr. Key's original webinar from February 14th of 2024, promoting and supporting sleep health of families of infants, is available on the PHN Prep virtual community of practice, as is the corresponding professional resource by the same name. So both of these materials underpinned the suite of sleep tools that you'll see today. So if anything's not making sense, you can always reference back to these documents. As you're onboarding new staff, or returning from leave, or just need to see it again, know that this webinar will also be recorded. You can reference back to it at any time. We'll also make sure that the slides today will be uploaded to the PHN Prep virtual community of practice. All of the English resources are available for download from the virtual community of practice already. And please stay tuned for French language client-facing handouts. And the working group, not quite done yet. We're still going to create some type of a how-to video to support you in your analysis of a completed sleep, feed, and play tracker and how to connect those to sleep interventions. So at this point, Ricky, Nicole, and I would welcome any questions that you may have about these resources and this suite of tools.
Wow. Thank you, Anya, Ricky, and Nicole. I'll also share gratitude to the entire sleep activity working group, to Niagara Region for sharing the work that they'd already done with Dr. Hall. What an incredible suite of tools. I honestly wish that I'd had a lot of this information when I had young children. I've learned a lot through this process that I could have used. So I have shared a number of links in the chat for everyone today, linking you to the public-facing professional resources. As I mentioned, the entire suite of tools is available on the PHN Prep community of practice. If you're not already connected to that, please email us at phnprep@mcmaster.ca. So I'm going to take a look at what kind of questions that we're getting. So the first question that we've been asked today is, what about older kids that are say 3 and 4?
It's a phenomenal question because we know sleep issues don't stop at 12 months. The work, however, had to start somewhere. So we chose to begin well at the beginning. And the hope is that by sharing these normal expectations of sleep and encouraging families to develop pre-sleep routines and healthy daily routines from a very early age, like birth, and moving forward, we might actually be able to prevent some of the sleep issues that can come up with your toddlers. If you already have a toddler, it feels like the ship has sailed. What can you do then? Maybe that's a next step for a sleep activity working group, is to look at what happens at 12 months and beyond. So I don't have an answer for you today on 3 and 4-year-old toddlers. Nicole or Ricky, if you do, feel free to chime in, but I will say it's a great segue for future work by this group.
Thank you, Anya. So there is a question about what family visitors are delivering with regards to supporting sleep. The question was actually directed at Ricky, but I know at Niagara Region that there currently are no family visitors. Am I correct, Ricky?
Yes, you're correct. So we no longer have family home visitors, but at the time, our curriculum was adapted to be used in a team effort between the family home visitor and the public health nurse. So the public health nurse would go in, do the eat, play, sleep tracker with the family, provide recommendations, and then work with the family home visitor in order to follow up on those recommendations and support the client in implementing them. They had the same training. The intention was that everyone across the family health division at Niagara Region Public Health was speaking the same language, giving the same recommendations, and utilizing the same tools. So it didn't matter your designation. We weren't providing any kind of out of scope advice that would have impacted the family home visitors from not being able to share the details. So the intention really was just to work as a collaborative team and have key messages that were the same if they called into the telephone line or had a home visit.
Thanks, Ricky. And I think that answers Joanne's question as well. Joanne was asking or sharing from the perspective as a family resource worker or family home visitor that they are constantly dealing with sleep issues. So definitely relevant information in there for you. And as Ricky alluded to, has been used by family home visitors at Niagara.
And I'll just add to that too, Sonia, that
Mm-hmm.
as part of PHN Prep, we are creating resources sort of specifically for public health nurses. But that doesn't mean back at the agency that the team gets together and decides how these resources will be implemented and delegated, like Ricky said, collaboratively between the team that's working with the family. So don't feel from our end that we're saying these are nurse-only resources. Each team at each agency needs to think about and make intentional decisions about how this material can best serve the families in their community, and which staff or all staff or type of staff are the best to deliver that and support the families.
Thank you, Anya. This might be a question that Ricky would be able to answer because she worked really closely with Dr. Hall, but do you know if premature babies were part of the research?
I don't think I can answer that, unfortunately. They were more so looking at the transition. I think a lot of focus was on that 6-month piece when melatonin starts to develop and the sleep rhythm is created, and you're able to start seeing the consolidation of sleep cycles. So that will impact the interventions that you're providing. I don't know that adjusted age was looked at, but I can find that information out and get back to you.
Great, thank you. This person's asking, just wondering if you can provide a source for the crying it out so that PHNs can all provide consistent evidence in terms of why this is not recommended. I'm not sure if that would be available in some of the literature that's published by Dr. Hall.
I'm sure it would. In the list of references, we can go through and find specific ones, but we really wanted to move away from crying it out in the traditional sense where there's no intervention from the parent, there's no addressing of issues. If a child is left to cry for prolonged periods of time and there's an issue that's happening, they're sick, there's an injury that is potential, we want to make sure that parents are attending to their children, even if they are trying to provide a behavioral intervention. So as you look at our controlled comforting, which is a bit of an adaptation of crying it out if you'd want to reach that far, but it allows parental intervention during that time, just with specific time space in order to see, is the baby settling on their own? Are they just making louder sounds? Do we need to kind of prove that we're still here, we're available, but it's time for sleep and setting that boundary. So I can see what kind of resources are cited, but the key focus was on the controlled comforting method.
Thank you. Now we have a couple of questions here, which I might have anticipated that we would get. So this is with respect to the behavior-based strategies that we described, specifically camping out or controlled comforting. So a couple of people are mentioning that they recently attended a webinar by the Early Infant Mental Health Program at Sick Kids that talked about nurtured sleep and recommended responding to infant cues, which I think you're also recommending. And I think that's maybe where you can help to explain that a little bit further. But there was some suggestion that maybe those methods would be harmful, but I know we've talked a lot in the working group about conditions under which you would actually move to those interventions and all the work that would happen before then. So I don't know who would like to speak about that.
I can jump in again if that's okay, and then Anya and Nicole. So through the additional literature review that was done when we were adapting from the 0 to 12 month to the 6 to 12 month interventions for sleep with our workshop, there was a lot of literature that highlighted that there was no emotional or behavioral impact on the infant long term when utilizing controlled comforting or camping out in a healthy, supportive, attachment focused way. So just to be clear, we are not suggesting that these interventions are the interventions to offer to every family, nor do I think you bring them up necessarily unless the client is looking to change the situation that they're in. Something with the infant sleep realm that we need to keep in mind is that infant sleep is only a problem if the parent identifies it as being a problem. So if the child's waking up 4 times a night and the mom's like, here's where we are, or dad's feeling like, I think it's okay, we're feeling settled, then it's not a problem and we don't need to really address that. These interventions are really for families who have identified it as being a risk for their family. They've tried all of the methods that are very protective, like we've talked about, building the attachment, spending time during the day. There's no illness, there's no change that's happening, because imminent change in like routines, starting school, starting a new daycare, all of those times are not ideal to use any kind of behavioral intervention. So if we've gone through all of the possible resources, mom is complaining about her mental health, or dad is as well. If the individual who's parenting really is struggling and is looking for an intervention, they will find one. And it may not be as supportive to their child as the one that we can potentially provide to them with support and ongoing check-ins. So the intention of the controlled comforting and the camping out truly is to be a resource for the parents when they need it most in a supportive way so that it decreases stress for the parent. Because as we learned in the highlights from the literature review, the more stressed the parent is, the more harmful it is for the baby anyways. So you're really balancing out the parental or caregiver mental health piece with the infant sleep and attachment piece, and making sure that you're finding the right mix for that family, for their unique needs. They may try to provide an intervention that just doesn't work. And then you decide it's okay to stop. If it's not working for you, if it doesn't feel comfortable, you don't need to be consistent. You can just wait and see what happens next time.
Thanks, Ricky. Anya, did you want to add anything, or Nicole?
I just want to say, Ricky, that like summed it right up. I didn't have the opportunity to attend the infant early mental health presentation, but I do understand that other different and diverse information was shared. And that's, as a practitioner, it's hard because you're hearing different things from different resources. Imagine it from the perspective of the family, because they hear everything we hear and then more, and then they hear a comment about it from their friend and their neighbor and their own caregiver, and role models and people in their lives. So I think it's important that as a particular agency with a program, that there is at least some type of consistent messaging that's being provided by the home visiting staff that families are coming into contact with. So when they have all of these questions from the diversity of information that they receive, the staff visiting can feel really confident and competent to answer and provide safe and healthy and effective direction that's customized and tailored to the needs of the family and the baby at that time. And just like Ricky said, with balancing caregiver mental health, stress, and other things happening in the home, because those impact the development of the baby so significantly. And sleep may be one area, and we talked about all of the things that impact sleep that can be changed with minor changes through the family and their routine. So there's a lot of information out there. Families will pick and choose what they want and what's best for them. Our job from public health is to share healthy evidence-based information that might support their situation.
Thank you so much. Now I'm going to transition to some questions that are coming in about the sleep tracker. Do you know, or have you heard, how successful is the use of the sleep tracker? Maybe you have use of it yourself in practice. People are wondering, is it used by many parents? It seems to be quite onerous maybe for a family that may be lacking sleep or living with a postpartum mood disorder. What are your experiences?
Oh, I'm happy to take this one, but absolutely feel free to jump in and add, Ricky and Nicole. I want to come at it from a perspective from the parent-child relationship programs at the University of Washington, because although we mentioned that our sleep, feed, and play tracker is based on one developed in Niagara, and I'm sure Ricky will speak to that, it's also part of the sleep and activity program from PCRP. With their program, it's called a sleep activity record, and it's intense. It's a 7-day recall that it's sort of similar. You can add in other features that you might want to be tracking. And that's the one that NCAS PCI instructors are all trained on. We do a case study, we use it with families in pre and post sessions. And some health units across the province have picked up that tool and those resources with success. So I do feel confident to say that sleep and activity trackers can be helpful. I'll also caveat that with for the right family. And that's why Nicole really stressed in the introduction of that material that it is not the best tool for every family. And you're right, if there's a significant perinatal mental health disorder happening at that time, it's not time to start writing down everything that baby is or isn't doing. But for other families, and lots of families like that type of analytical data, or may already have access to it through an app that they've been using, it can be a very helpful and beneficial tool. So far has been my experience. But Ricky, I know you want to add to that.
Thanks, Anya. I think that's great, and you hit on all the points that I was hoping to make as well. From my experience in Niagara Region Public Health, we like the Eat, Play, Sleep tracker. It helps identify patterns. So, as Anya said, with the right family, it's an excellent tool to be implemented and to give a picture. They don't have to do all 5 days if they don't want to, but they might even just in their own time notice and pay attention more to the patterns in their child's behavior without even completing it fully. Obviously, if they do it in the way that we're hoping that they do with the full 5 days, and then we can analyze it, we're able to bring so much more to the table as far as recommendations and work with the family. But just having the family as becoming more intuitive with the patterns of behavior and the sleep patterns of their child can help make a big difference in how they anticipate that child's needs, read their baby's cues, and then I address those cues and what their needs are.
Ricky. All right. Is there a sleep strategy that would be recommended over the other to help transition infants from co-sleeping to sleeping in their own space?
I have nothing to add here. Co-sleeping was very specifically an item of exclusion when we were doing research and review and analysis of existing information. So I don't know, Ricky, if you have other detail to add, but the PHN Prep Sleep Activity Group really did not look at co-sleeping.
Mm-hmm. So with co-sleeping, again, it's a reliance. That's their tool to fall back asleep for the infant. So just like with a soother or a bottle, the infant is not able to fall back asleep without that specific circumstance or intervention in place to help them maneuver through their sleep cycles. Which leads into, again, why we waited until the 6-month to 12-month piece to start using interventions, because they're able to consolidate those sleep cycles and move through them without having those aids. So while I don't think I can speak to co-sleeping and ending co-sleeping and the strategies for that, because there's so many attachment pieces, there's breastfeeding pieces that are associated with co-sleeping as well. I will say that it is something that's a habit for the baby, and you have to figure out how to navigate through those reliances as they're consolidating their sleep.
Thank you, Ricky.
That's a great point, Ricky. And I'll just add to that, there are embedded in the resources some detail about how to replace undesirable sleep associations, or ones that families no longer want to participate in, with desirable sleep associations. And that's not from our perspective. I'm not going to call out which is a good or wanted or bad or unwanted. But when the family is saying, I have really enjoyed rocking my baby to sleep, I can no longer do that for whatever reasons, there are some steps embedded in the resources on how to insert another wanted sleep association in there so that you can over time remove another. So I do wonder if there's some way to work embedding an alternate wanted or chosen sleep association in at that time as a family is considering moving away from co-sleeping.
Thanks, Anya. And I think that answers another question that someone had about the reason for not talking about co-sleeping. We did address sleep associations. Oh boy, is this ever bringing me back as a co-sleeping parent who did successfully transition my child I would say I used the camping out method. I didn't realize I was using the camping out method until I started talking about it with this group. But I slept many nights on a floor beside a crib, and it all worked out for us. Okay, so I don't think we thought about this. Maybe Ricky has more insight. Historically, are there any additional resources or considerations for families with multiples? Not something we looked at, but I don't know if anyone has come across that in any of the other resources or references.
So there's nothing specific. I know in our workshop, we kind of addressed multiples. And again, making sure you have those routines is so imperative, and making sure they have like their separate sleep spaces and you're giving them each time. We have some great nurses here at Niagara Region Public Health that really dug into these sleep topics. So I'll pick their brains and see if they have anything they want to share back with the group.
Thank you. Someone has asked, do you have a client-directed information sheet created? Maybe that's, we do have like client-facing resources have been developed. There were 4 of them presented. 2 of them are fact sheets, which essentially would be a client information sheet. One focused on birth to 6 months, and one is 6 to 12 months. Those are to be accessed by public health nurses, though. They're not posted anywhere publicly for clients. Maybe that's the point to be made here. It would be up to a nurse to share anything with a family. Does anyone want to add anything onto that in terms of how we imagine the use of these materials?
I think that's a great point, Sonia, is that the intention is that the nurse or the individual that's providing the information is there to have the conversation with the family. If these resources were available out in the community, just ad hoc without the health teaching, the fear would be that we are encouraging use of behavioral interventions as their first option. And we want to make sure that the parents are in the right space, they're mentally prepared and supported, the child is healthy, all the things that we've already talked about. We want to make sure that we're adding the health teaching with the intervention instead of just allowing it to be broad.
Thanks, Ricky. There are lots of comments coming through with thankfulness and like so helpful to have these resources. I just want to share that with all of you. There is a question, it's more directed at PHN Prep. It's asking if we can anticipate more tools on different topics, especially client-facing tools from PHN Prep in the future. That's a difficult one to answer. I mean, the scope of our work has really been to support public health nurses in the work that they do. This sort of came out of, we're still supporting public health nurses to do their work, and these client-facing resources will help them do that. I think there is a possibility in the future, maybe, that we would also do the same. I think the most important thing is please share with us what you think would be important for improving and building on your professional nursing practice at your health unit, and what you think should be the focus of PHN Prep. We love hearing your ideas, so you can always reach out to us at phnprep@mcmaster.ca. We continue to really be supporting a lot of the perinatal mental health work that we've been doing over the past year, and our next year is really looking at helping to build and continue doing much of that work. But as you know, we're always taking ideas and working on resource development. So please reach out. Do any of you have any final words that you'd like to leave everyone with?
I would just like to follow up. I think you've answered that really, really well, Sonia. And just mention as well too, part of the PHN Prep practice guidance framework that's followed when developing these types of tools includes that consultation back with the end user. So watch the PHN Prep newsletter, engage when PHN Prep reaches out with surveys. That's one way to know too where time, effort, and energy is being spent by PHN Prep, so that you can think, oh, we're also working on that. Reach out because we want to work with you, or know, okay, they're asking some questions, so something might be coming in the future. You've all seen Sonia many times. She's friendly, she's amenable. You can reach out to her and ask those things. And we love your answers and responses when we have the opportunity to survey about will this work for you? Is this a meaningful tool for you? Because we don't want to misdirect any time, effort, and energy. We really want to go where the support is needed and will be effective. So I just add that, Sonia.
Thank you. Thank you for the plug about the PHN Prep newsletter. That is one way that we've really been trying to improve our communication with health units. Okay, I do see one more question coming in. One of the basic things we see families struggle with are routines. Is there something specific we can help families with in regards to having challenges with infant sleep? Take a look at the suite. That's my advice. I believe there is lots in there that will be able to help you.
I fully agree with that, Sonia. Today really focused on the end of day routine, a pre-sleep routine. It's also called a bedtime routine, but we're trying to be cognizant with our language. So there's a lot of emphasis on that part of the day, but even the sleep feed play tracker, it's a 24-hour recording. So nurses want to see what's happening with the family all day. And there are some measures within the suite of tools to support what could be happening during the day as far as developing those routines go as well. So yeah, you're totally right, Sonia. Look at the suite. There's lots of information on there. It focuses on nighttime and bedtime routine, but it certainly can be applicable throughout the entire day.
Thank you, Anya. All right. Any other final words? Nicole, do you want to share your experience being part of the working group? Thank you so much for being part of this presentation today. You did an amazing job sharing those resources. I'm putting you on the spot, aren't I? Oops, sorry, I see you're on mute.
Sorry, I'm having technical difficulties with my mouse. Yeah, the working group has been amazing. It's been amazing to meet other nurses from other parts of our health units. That's been really, really valuable. And then being able to share all this information at our home centers. Yeah, it's been a monthly meetings of getting together. So yeah, it's been really good, and I'm really excited to start using this myself. Definitely being able to create these sleep plans with families and work through this and do our assessments and our relationships with their families. So yeah, it's been great.
Thank you, Nicole. And I'll throw a hearty thank you out to each member of the working group and to Ricky and Debbie, who couldn't be here with us today. The time, effort, and energy put forward for these materials was immense. A thank you also to your managers and supervisors who supported your involvement in being engaged with this group, because we really couldn't have done it without the nurses in the working group. So thank you, Dream Team.
All right. So everyone will receive a session evaluation if you've attended today. I think someone just posted into the chat where the link is, if you're able to do that now. Otherwise, I just want to thank everyone. Thanks for all the comments for everyone who's been participating. I'll pass it over to Andrea maybe to close us for today.
Hey there. Sorry, you're getting a wonderful view from my webcam, but I will just say thank you so much to all of our speakers for your wonderful presentations today. Such interesting and such important work. I want to thank each of you for joining us today, and for Sonia for co-moderating with me, and a special thank you to everyone who joined us for today's webinar. Thank you so much, everyone.